Thank you, everyone. Today's my topic is about the TELD using EndoSurg PLUS system. TELD is the transformal endoscopic lumbar discectomy. So we have a quick look at the anatomic details of the inner body. So from L1 to L5, you can see the femoral space is much narrow, smaller and smaller. But from the L1 to L5, the in the laminal space is bigger and bigger, and the shape of the intervertebral foramen will depends on the different degrees. From the dorsal side, you cannot see the intervertebral foraminals, but when you rotate a little, about 30 degrees, you can see the foraminal. At 90 degrees, we will see the foraminal at a very big space. And now we present a very important structure called Cambium triangle. The Cambium triangle is we think about is the safety triangle for the transforaminal approach. It's shaped like a triangle and it locates over the dorsolateral side of the intervertebral disc. So the Cambium triangle is not just a plane, but a three-dimension space. You can see we have the traditional safe triangle on the right side. You can see the traditional triangle is much more higher than the Cambium triangle. So the traditional triangle, safe triangle cannot take out as much disk space as the Cambium triangle. And the Cambium triangle is much close to the central side. And the traditional safe triangle will define by the nerve path and will be easy to damage the exiting route. Now, there are mostly three approaches for the PELD, like transforaminal, interlaminar, and posterolateral. For most cases, we can use transforaminal approach and interlaminar approach to the herniation case. But some cases has a extra foraminal herniation. At this case, we will use the posterolateral approach to take out the disc. And this is the history of spinal percutaneous endoscope. We like to introduce the two important techniques. One is presented by the Anthony Young, so-called Young technique, and the other is designed by the German Professor Buchland. It's called the TELD technique. You can see the classic Young techniques will not resect the SAP, but the foramina is not large enough to put the whole working channel into the foraminal space. So it can only face to the disc. But this is difficult to sieve the nerve root, and it is also difficult to remove the disc protruding into the spinal canal. So in order to achieve the spinal canal, we need to resect some of the SAP. So the TELD technique is coming out. The TELD technique will allow the working channel into the foraminal space. But we need a multiple X-ray to make sure the location and the safety during the operation of the TELD technique. So where should the expansion should be performed in the foraminal region? As this picture 8, you can see at the triangle, there is a exiting nerve root near the walking channel. So in some cases, the foraminal space is very narrow. When you put the walking channel into the cabin triangle, will be easily to damage the exiting nerve root. So also we will need to take out or resect part of the SAP to allow we avoid the exiting nerve root. This is the picture of the SAP resection. Mostly we will only to resect the blue area, like the SAP, the tip of the SAP. We can finish the foraminoplasty. But in some case, if the space is very narrow, we usually need a second, we can use a secondary foraminoplasty at the red area, so to enlarge the walking space. In order to perform foraminoplasty safely and efficiently, some lecturer has reported the approach of superior vertebral notch foraminoplasty. You can see at this picture, we point to the target at the superior vertebral body. Sometimes we need to resect some of the vertebral body here. Another technique is called the walking technique. There is a 4-point here, 1, 2, 3, 4. The first time we use a guide needle to place on the SAP surface, and then the surgeon will move the needle slowly and gently to the downwards to avoid the exiting nerve root from 1, 2, 3, and then go to the 4x place. But when we using this technique, we find out it requires the very excellent experience from the surgeon. And in order to ensure the accurate precision, they will need many times of X-ray. Some people are also to have an approach of tube is so-called obturator guiding technique. It uses a walking channel to slide from the SAP to the foramina. We also use this technique too, but it will be challenged to locate the bony structure in some OPSI patient. And for patients with osteoporosis, there will increase risk of damaging the articular process while during the exploration. And some surgeons also perform the foraminoplasty safely and rapidly through designing and improving the surgical instruments. But again, this kind of technique will not perform under visualization. They will need many times of X-ray. And some cases have severe migration, like these cases. It is very difficult to expose the whole disc, and will increase the surgical difficulty. For caudal migrated herniation, we will need to remove some of the ventral surface of the SAP and resect a partial of the pedicle to allow the endoscope to downwards to directly observe the intervertebral disc. And for the cranial migration herniation, the puncture point will be positioned at the lower part of the disc to avoid irritating the exiting nerve root, and then gradually shifting the endoscope upwards, enable to explore the cranial migration fragments. In the previous topic, we discussed about the endosurgery theory, and now we will introduce the new technique, so-called EndoSurg PLUS system. This is a two new device and new techniques. We will use the visual reamer to do the efficient and safety bone cutting, and we will have the U sleeve to retract the soft tissue and T leaf to retract the nerve root. Just like this, we can only put the working channel into the outer edge of the SAP process, and then take an X-ray to confirm. And then we don't need to another X-ray because we will do the bone cutting under the visualization. It is very safety because it is far away from the nerve root. Now I will present a case and introduce the surgical procedures. This is a male patient. He had right hip pain for a month and for more than 1 year. The diagnosis is LDH for the L45 level. You can see the L45 foraminal space is a little bit narrow here. This is the pre-op CT. There is no ossification of the L45. And the pre-op MR shows that this is a big herniation. So before the surgery, we usually use some hemostasis drug, like stop using the clotting drugs before the surgery. And the blood pressure, we will make sure around 110 over 60. And during the operation time, to avoid the cerebral vascular accidents. And we usually need the CT MR to make sure to know about the fascic joint morphology. We recommend general anesthesia or lumbar anesthesia because it will be comfortable to the patient during the surgery, and the blood pressure will be controlled. But some surgeon can use the local anesthesia because the patient will think about this is the advantage of we let the patient stay awake so that he will know whether you touch the nerve root. It can reduce the risk of nerve root damage. And the position, we recommend prone position because we usually the most surgeon is familiar for this position, like the traditional open surgery. And this position is very stable, and it is convenient and easier for doctor to operate. But the lateral position, some doctors think it will feel comfortable and no pressure for the breathing for the patient, and it will utilize the lumbar bridge to enlarge the intervertebral foramen. This is before the surgery. We will take the X-ray and draw the surface projection on the patient. The four round here is the pedicle projection. and we draw a line. This is the intervertebral space line here, and this is the length of the L is the two pedicles distance from left and right. This is we mark it as a L, and the puncture point is lateral 2L distance from the pedicle point. This is the surgical technique. We draw the surface. Projection of the two pedicles. Mostly is the 8 to 9 cm away from the midline, and the puncture and soft tissue dilation. First, we use a needle touch the surface of the SAP, and then we insert the working sheath. And then we will insert the T-tube. And put the lens into. And then we will expose the surface of the SAP. First, we need to clean the soft tissue and stop the bleeding using the RF probe to locate the bone structure, and use the RF probe to stop bleeding, and expose the SAP margin of the pedicle, and expose the pedicle towards the caudal end. And then we will identify the posterior superior aspect of the vertebral body. Now you can see the round yellow red round here is the anatomic landmarks. We need to identify it by using RF probe to clean the soft tissue and expose this bony structure. And then we clean the foraminal ligament and expose the dorsolateral intervertebral disc. As you can see, the RF probe is touching the intervertebral disc here. And then we take out the T-tube and insert the reamer. So we now to perform the foraminoplasty. You can do it like using the visualized reamers and introduce between the working tube and the body of the endoscope. First, we rotate the reamer to cut the soft tissue anti-clockwise until the reamer enters the bone. And then we rotate the reamer quickly on the clockwise until the bone fragment is loosened, and it will rotate with the reamer together. Now the reamer is into the bone. Now you can see the bone is loosened, and we can use the forceps to take out and stop bleeding. Every step we need to make sure there is no bleeding, because too much bleeding will blind the lens. It's hard to see the structure clearly. And then after remove all the femoroplasty, remove the bone, usually we will see the yellow ligament. And then we will introduce this sandwich structure. It is defined by the yellow ligament up here, and in the vertebral disc down here. At the middle, there will be the nerve root inside. So this is called a sandwich structure. When we cut off the lateral edge of the yellow ligament and observe the dural fat at the spinal canal, it indicates that the nerve root is nearby. And then we will have a tension here. Usually we will have a company veins around the nerve root. We must be careful to avoid it bleeding, and use the RF probe to hemostasis before we cut it or damage it. And then we replace back to the working T-tube and start the decompression. If the patient has spinal stenosis, dorsal decompression is required, including resection of the yellow ligament and through the decompression of the dural matter and nerve roots. However, this patient is young and has only simple herniation disc, so the dorsal decompression is not necessary. Therefore, I will try my best to preserve the yellow ligament. And now you can see, as we cut off the yellow ligament and show and expose the disc, we will very easily to find out the herniation and try to remove the nucleus pulposus as much as possible. But we need to protect the PLL as much as possible, because the PLL can reduce recurrence and reduce adhesion and help the annulus fibers heal quickly. If the PLL cuts too much, when a patient needs a second time surgery, it is very difficult because many patients will have some adhesion. After the surgery, we will have a check for the patient, like assist the patient to twisting their waist, so that to find out whether some nuclear pulposus is squeezed out from the intervertebral disc. To do this, we will reducing the possibility of the recurrence at a short time after surgery.